Thanks so much for inviting me along, and morning everybody. So I'm Alison Turner from Strategy Unit, and over the past few months I've been working with a few colleagues on a small project looking at failure demand, which was commissioned by the Health Foundation. And what I want to do today is just share some of what we learned, but really invite a bit more discussion as well. So I'm really interested in hearing your thoughts and reflections, whether this concept resonates with you, whether it feels useful, what it might mean for your work. So we're hoping to keep this sort of quite a reflective, interactive session today. So there'll be various points where I'll invite you to reflect and share. We've got the Sido questions, but we'll also invite you to share in the chat any thoughts that you've got and any comments, and do ask questions. So I'll try and remember to pause at certain points to check if there are any questions, but do pop your hand up if there's anything that isn't clear. So today's webinar is really the sort of closing part of this little project that we've been doing, and we really wanted to explore what this concept called failure demand is, and whether it might be useful for helping frame productivity and value in the NHS. And so as you're listening today, it might be helpful for you to sort of reflect on your own context. Where do you see demand that arises because needs weren't fully met the first time round, and what might that be telling you? And we'll talk a bit more about definitions and stuff as we go. So I'll just give a little bit about my background so you kind of get where I'm coming from, because I'm not an analyst and I'm not a sort of improvement expert in any way. My background is evidence synthesis and knowledge mobilisation. So my role is really about bringing together different strands of knowledge and helping people make sense of that to inform decision making, whether that's sort of policy or strategy or whatever. And I'm really interested in what happens to knowledge when things get complicated and messy. So when systems are under pressure and capacity is constrained, and how we bring in sorry, that's my phone ringing, it's just spam. And how we value different forms of knowledge, like lived experience and things like that. And this I think failure demand seemed to be quite a contested sort of space, so I was particularly interested in that. And actually when I started this, I thought, oh gosh, this is all going to be about productivity, and that could be quite dry, I guess. But actually it's a lot more about people, and I think that's what makes this a really interesting concept to get your head around. So briefly, thank you to the Health Foundation for funding this project, and particularly thanks to Francesca and Ellen, who helped us all the way through the project and kept us going with challenging our thoughts and reflections, and providing all kinds of support as well. Now at this point, I wanted to run that quick poll just to ask, because I'm curious to know if this is a concept that's familiar to you. So I hadn't really come across this term before starting this project. So I think, how does this work, Rachel, with the Slido question? Will people just be able to, I can't see the screen to see if people have got the link and are filling that in.
So what I'll do is I'll share my Slido screen, and people then will be able to be reminded of the number and also the QR code that's on there as well. So we can see that people are joining that screen. So just give them a minute or two. But you can talk about the options that you've got here.
Yeah, so I think I was curious to know if you're familiar with this concept. So are you familiar, and you kind of feel, actually, yeah, I know it enough I could explain it to other people. Are you sort of familiar that you think, yeah, I kind of get it, but I'm not sure I'd explain it? Or have I not heard of it at all? Or are you sort of like, oh, I don't know, maybe it's sort of vaguely ringing a bell, but I'm not entirely sure. So it'd just be kind of interesting to know what levels of familiarity you have, I think, before I get into this, because I can spend a bit longer on definitions and so on. Aha, there we go. This is reassuring, because it means I can cover some of the definitions as well. Brilliant, that's really helpful. So thanks so much for filling that in. So what I'll run through today is I'll be talking a little bit about why I think this concept matters at the moment. Talk a little bit about what it is, and then sharing a little bit. We've developed an exploratory typology, which we're hoping helps make sense of the concept, because we found it is kind of a bit of a slippery concept. And then we'll talk about some of the implications and what that might mean for the NHS and for you know all of our different roles as well. So just very briefly, just a bit about how we went about this, so you've got a sense of you know what our report is based on. So we had sort of 3 strands of work looking at the literature.
Alison, sorry, do you want to share your slides?
Oh gosh, sorry, I completely forgot I wasn't sharing. Oh no, gosh.
That's okay.
Let me just find. Yes, sorry. Oh,
they're
brain
overused.
not working.
Slides are overused.
Brain not working today.
Yeah.
Right, there we go. That's back on, isn't it? Fantastic.
It is.
Yes, so yes, you haven't missed much. This is the first slide. So yes, we've brought along sort of worked on 3 different strands. So we started with the literature review, looking at reports and journal papers. So from policy, academic research that explored this concept, mainly focusing on healthcare, but there were papers from other sectors as well. So, for example, the police, housing, and I think social care as well. And then followed that up with about 22 interviews with people who have got expertise or experience working in this sort of space. And there was a lot of what we noticed was people coming at this from quite different perspectives. So we had, and some of that was down to, you know, the sort of disciplinary background. So we had some people from an engineering background, some from a clinical, some people had both. They had both engineering and clinical qualifications. And then we had some people who were more sort of operational management or about quality improvement. And they also brought a slightly different perspective. And what we found is some people were sort of quite focused in on a particular aspect of failure demand, and others were sort of taking a much broader view. So we sort of developed our findings, and then we held a stakeholder workshop to sort of test some of those findings and see if what we come up with made sense, and sort of checking and challenging some of that as well. So we spoke to a lot of different people, and it is a bit of a contested space. So I mean, I don't know if you've looked at any of the discussions on LinkedIn, for example. There's occasional arguments about what failure is and failure demand is and isn't. So our work was trying to sort of make sense of this, to drive. And initially, I suppose our main audience for the work was policymakers and system leaders, to just sort of get some sense of what we might usefully use this concept for, really, and to sort of trigger some conversations about this. So it's been the concept's been around quite a while, but the evidence base is quite underdeveloped. So there's not an awful lot of sort of research and peer-reviewed type papers. There's small case studies, but it's quite fragmented, I'd say, as a knowledge base. So you might be wondering why we would do this now if the concept's been around for such a long time. And I guess we were interested in, you know, the productivity paradox that is being talked about, this sense that across the NHS, our activity is increasing, you know, more appointments, more referrals, more tests, but the outcomes and experience aren't necessarily keeping pace. So that's health outcomes, patient experience, but also staff experience as well. And there is this sort of commitment in the 10-year plan to a 2% productivity gain over the 3 years. And we know from public surveys as well that the public are also asking for more efficiency from the NHS and more coordination. So we wanted to sort of get a sense of how useful this is as a lens to explore productivity and value. So essentially, sort of reframing questions about productivity. So really thinking how much of the activity that we're doing doesn't need to happen. So how, not so much how we better analyse demand, but how do we distinguish demand that sort of reflects genuine need from the activity that's generated from our own sort of issues and sort of failures in the systemic design. So again, it's really about asking this question: what if some of the demand we're seeing is demand that we're generating ourselves? So it's not necessarily new need, but it's unresolved need, sort of cycling back because we haven't really dealt with it appropriately the first time round. So it's sort of, I guess, unmet needs, poor coordination, delays, communication failures. So essentially sort of systemic design issues, really, about how we design processes, pathways and interfaces. And that's really, I think, what failure demand is trying to sort of name and reveal. So it kind of, I guess it's interesting because it kind of shifts the conversation a little bit. So rather than assuming rising activity equals rising demand and rising need, it invites us to think about whether, you know, some of that demand is from our own gaps that we might be able to then address. So just very quickly, I'll talk through some of the definitions. So these are definitions that are most commonly used in the conversations. These come from John Seddon, his consultancy called Vanguard Consultancy. And John Seddon is the person that coined the concepts in the first place back in the 1990s. So failure demand is often, it's generally stands in contrast to value demand. So value demand is all about what a service or a system is set up to do. So it's sort of delivering what it's designed to do. But failure demand is really about the work that arises, so extra contacts, extra appointments, extra workload, because we haven't addressed a need effectively the first time round. So it's extra burden, I guess, really. And the point about it is that it's failure demand is the problems that are baked in to how we've designed processes, systems, services, and so on. It's not about individual performance. So it's not about it's not a concept of blame, and it's not about mistakes or medical errors. It's really about that, how we've designed the way that we work as a sort of overall system. And there are quite a few examples. I'll come on to some examples shortly, but I just wanted to, before going into that, I just wondered if I wanted to invite you to think of an example from your own context of, you know, where have you seen failure demand, or where have you seen or experienced it? Where do you see it in the data, for example, that you're analysing, but also in your experience as a patient, maybe as well, you might have experienced it at the other end as well. So I just wonder if you would like to sort of take a minute to reflect if there's an example that occurs to you, and it might not be in healthcare, it might be that you've experienced this in other settings as well. But just have a think, is there an example you can think of where, you know, there's been avoidable work because the need hasn't been met the first time round? And for now, if you just jot it down, and I'll invite you to come back to that a little bit later on. But this is just, I guess, this is just helping us sort of ground this concept in real world examples. So what we found was that the concept is kind of intuitively, it resonates with people, but actually when you try and pin it down, it's quite difficult to think what is failure demand and what isn't failure demand, because I think when we first started on the project, we almost felt like everything's failure demand, and then it becomes less useful as a concept. So I'll come back to that in a little while, but yeah, if you just want to jot down any thoughts you've got, an example you can think of, and then hopefully we can talk a bit more about those later. So I think one of the problems is that failure demand looks like normal activity. So, you know, repeat contacts, additional appointments, sort of downstream utilization would maybe look normal. You know, a repeat appointment just looks like another appointment, and so on. So it's sort of, I guess, when we talk to people, a lot of people thought it's a useful concept for sort of explaining this productivity paradox, that, you know, we're not necessarily seeing increased outcomes at the same rate as the activity is increasing. And if we're looking at activity, then all this counts as output. So the activity, even where the activity is rising because we failed to meet the need the first time round. So activity can increase, but the value being created can stay flat or even fall off as well. So I guess it's one of the most useful concepts, I suppose, from this, is that activity does not automatically equal value. So rising activity doesn't mean rising value, and I think that's what we're seeing with some of the this productivity paradox. So the central sort of output is this exploratory typology that we came up with. So, like I said, when we talk to people, there were so many different views about what failure demand is and isn't, and this was our attempt to try and make sense of that, because it's almost like we just needed some kind of visual representation of this, so that it just, you know, it otherwise it feels like this big amorphous sort of thing that you can't really pin down. So what we wanted to do here was try, and we're not really describing types of failure demand, it's more really the sort of signs and symptoms, if you like, or of failure demand. So it's often, failure demand is often described as a signal of a problem, and what we wanted to describe was the sort of signs and symptoms that might be useful signals. So like I said, the concept resonates, but it is messy, and what we found was, because of this sort of contested space, I guess we just needed something to be able to grab hold of a little bit that would help people to explore this, and understand it a little bit more. So the typology is based on this idea of the NHS as a socio-technical system. So there'll be some processes and activities that are quite sort of technical, transactional, like booking an appointment. And then there'll be other activities that are much more sort of social or relational, which is, maybe supporting people with long-term conditions, and trying to help people stay out of hospital, for example. So the typology is organised around two dimensions, one of which is this sort of type of activity and the complexity of the need and the response. So ranging from the transactional, so that might be the sort of discrete bounded tasks, through to this sort of more relational side. And I don't know if you've come across, I recently came across this term called relational density. Somebody called Joseph Badman was talking about it on LinkedIn, and it's how much relationship is needed for a service to work. So as you move to the right, that sort of relational density gets a bit thicker. And then the second dimension, sort of vertical axis, is where that failure demand arises. So is it within a service, or is it an interface between services? And then this sort of gives us 4 domains, and the reason why we think this helps is because the sort of types of signs and symptoms here and where it's happening sort of warrant slightly different responses. And so, in the sort of more technical side, it might be more around process improvement, for example. So I'll just describe the 4 domains, and then what I might ask you to do is to think where the example you thought of might occur in that domain. So it's a helpful way of sort of thinking through some of the different types of examples that we've got. So operational frustrations, this is sort of within a service, and these are things that we've probably all experienced, problems with booking appointments, communication problems. So we had a webinar last week where Jacob Lant was talking a lot about appointment letters arriving after the appointment has been and gone, and things like that, but also supply gaps. So there's lots of problems around supply of particular medication at the moment. So often people are turning up to a pharmacy only to find that they can't get the particular drug that they have been prescribed, and then have to go back to the GP to get the prescription renewed and or reissued. And these are the problems that seem to be most amenable to process improvement, because you can sort of map the process, identify where the problems are, and sort of relatively straightforward to fix them. But if we move across to the more relational side of things, what we call rule-bound services, and these are where services are sort of set up with quite rigid eligibility thresholds. And a really good example here is the continuing healthcare, and you might have come across work by the Nuffield Trust recently from King's Fund, which was published last week. So I can't remember the proportions, but a massive proportion of people who fill in the full assessments for continuing healthcare are turned down. And so, and that generates, I think somebody was telling me it takes about a week to do an assessment. So it's generating an awful lot of demand when it's really not clear because of the eligibility thresholds and so on. And then another sort of aspect around this is the support needs when we're failing to identify support needs. So, for example, people who need access to interpreters or sign language, for example, but also people who, if they had home adaptations to help them live more independently, it might prevent falls and things like that. So there's something about understanding or building in feedback loops to sort of understand where some of these problems might be occurring, so that we can identify some of these problems and try and sort of stop this cycle of repeated demand that's occurring because we're not addressing the needs fully. Then if we move up the typology to the between services, so on the left hand side we've got delays and blockages. So this is probably an area where there's more work actually, and probably some of you have done an awful lot of work in this space. So, you know, around flow disruption, long waits, generating further demand downstream and so on. And these really warrant a sort of system level redesign. So they're not perhaps so easily fixed as the operational frustrations. And then moving across to the relational side, we've got disjointed care. So there's lots of different sort of, I suppose, signs and symptoms of this. You see poor transitions. So, for example, from children's services to adult services, you know, that's a sort of gap that we've known about for a long time, that people sort of fall through the gap, or, you know, because that transition isn't managed, it sort of creates more demand. And loss of continuity is something that there's an awful lot more evidence about, particularly in primary care. And then there's this concept called pixelation, which came from the Changing Futures work up in Northumbria. This sense that, you know, it's sort of focusing in on one small part of a person's need rather than the sort of entirety of what they need. So it's not really addressing the underlying problem. And in this space, there's an awful lot of evidence emerging now about relational care and relational services, which is really interesting. And so it's much more. So for the Changing Futures, there was a work to link data across the NHS, criminal justice, I think social care and housing, and various other public sector data sets. And they started to explore, you know, that I think there's a really famous case study called Brian, where they show, I think it's called a theograph, and it's got all these sort of contacts, and then they sort of, when they take this relational approach, they start seeing white space on the chart, and because they're able to sort of address those underlying needs, and you know, the number of A&E visits reduces massively. So it's a really fascinating case study, and there's a lot more work coming out in that space. So I guess the key message is really that understanding the sort of signs, symptoms, and so on it matters, because it helps inform the response and the appropriate response, really. So if you treat a sort of relational problem as something that's just sort of a process issue, then, you know, perhaps the response is going to fall short a little bit. So the idea of this typology is just really to give a bit of a starting point, a practical starting point for thinking about failure demand, identifying it. So we're not, and it's not really trying to close it down into categories so much. It's really trying to open up the discussion. So it's just really there as a sort of aid to thinking rather than a sort of prescriptive tool necessarily. So what I was going to invite you to do next was to think back to that example that you've just jotted down, and think, actually, does that fit into the typology? Does it fit into the operational frustrations, rule-bound services, delays and blockages, or disjointed care? I'll just flick back so you can see the diagram. Or does it not fit? Because this is part of us testing the exploratory typology as well. Is there something that you think, actually, I'm not sure if it fits into those categories? So if you're happy to, I wonder if you would be, I think, Rachel, can we use the chat for this? I think this was one of the questions we were going to do in the chat, was it? I think not on Slido.
Yeah, so there's two options. For those who can use the chat, you can pop things in the chat and we can pick them up there. In Slido, you've got the Q&A option. So you can just go into Slido on the same link, and then you can just see, but I'm just thinking if people have joined late, they might not be able to see the, let me just, yeah. They won't be able to see the QR code, is what I'm trying to say.
Oh, yes. I wonder if, shall I pop back to the first slide and pop the Slido link back up? If I do that quickly?
Yeah, I mean.
So there we go. If you have joined since we've put the Slido link up, you can either click that QR code, or I think if you go to slido.com and enter that code, that should work too. So I'll just give that a minute in case you need a minute to find that.
And you'll need to click on, you have an option to click on the actual question or the Q&A. You should be able to pick the Q&A as well from that. But I don't know. I know someone's found out how to do it, but I don't know how easy it is, because I haven't tried it myself. Okay.
Yes, because I think we're just very conscious that sometimes people, when they join the webinar, because of various firewall and things, they don't always have access to the chat. So that's why we're sort of offering both options, I guess, really. So hopefully that's given you enough time. I'll just flick back to where we were. So yes, so I guess if you can place your example somewhere on that matrix, where would it sit? Does it feel like it's contained within a service? Does it feel like it's something that occurs across the interfaces between services? And is it sort of more of a tech transactional sort of, not a glitch, but a process issue, or does it feel like more of a social relational problem? And I think yes. So I think I will move us on, but I'm just wondering whether we can. Let me just see if I can bring up the chat to see if there's anything in the chat or the Slido. I don't know if there's any examples coming through, Rachel. It's worth just reflecting back.
No, so so I'm not sure people are, it might be easier for people just to shout out. So if you are able to go to the Slido, you click, instead of the poll, you click at the top of the page on Q&A, and so we have got some examples coming through now. So shall I just shout them out?
Oh yeah, that would be good. Yeah.
Okay, so some examples. There's some questions because it's a general Q&A, and we can come back to those later. So people are saying sort of relational within a service. Do we put our VNF demand example in here as a question? Do we? I would say yes.
Oh,
I would
yes.
say yes. And someone says they're thinking about healthcare stroke hospital departments not talking to each other, so disjointed care maybe. I'd say that's almost definite. I like this one. Someone says it's too rule based. Computer says no. So they're that's sort of moving away what should be more relational, or basically understanding the situation better, and then maybe sort of offering the wrong kind of support or service. Someone's got some recent family experience with failure demand in hospital, definitely disjointed care, agencies not speaking to each other, delays and blockages, failure to communicate, which is one I can relate to, probably about 50 times with my father in the last few years. So, and it's a very common situation, isn't it? And people have lots of examples and struggles as well. I suppose just specifically with that one, without sort of derailing your talk, Alison, there's a lot of sort of the communications between these different agencies, and it is complex, but it's also sort of quite often you're sort of mediating on behalf of somebody who is not able to sort of directly sort of say what they think and feel. So I'll just read a few more out because there's lots coming through. So someone suggests the entire system of 111.
Oh, well,
in terms of delay and blockage. I guess again that's another example where people have had lots of experience of where that hasn't necessarily worked for them, and it's caused more problems. Someone else is saying a lot of operational frustrations. For example, need an X test before Y appointment, but Y appointment happening as because the test was not booked. So there's a lack of ideal sequencing, again, sort of communications between different services and things like that. But poor quality probably kind of hits all four of your lovely quadrant. He or she doesn't say lovely quadrant. I'm saying lovely quadrant. I really like that. I really like the way that sort of describes it. Pharmacy first. Somebody's saying that's an expensive delay and blockage. So some very sort of specific examples of people's experience, whether it's in their own areas of work or whether it's within own personal experience. It feels like there's a lot of both. It's a really nice sort of mixture here. Someone saying like the wrong location, putting on a letter, things received too late, lack of interpreters, they're cancelling the appointment. So in the data, it would look like a DNA or the cancellation of appointment. They won't say why necessarily, but it would look like legit activity after that, won't it? So that's what you were saying. It looks like in some cases sort of productivity. It looks good. It's, you know, we're getting all this stuff done, but in actual fact, if you'd done it right in the first place, there would be it would be more straightforward.
Absolutely.
How many more do you want? I've got.
Oh, that's probably fine. And then no, that would be great. But keep them coming because I'm really interested in because I think
I'll
that'll
share
be
them with
useful to see that afterwards. Yeah, thank you very much, everybody.
Okay.
So I'll just flash up. So sorry, this is like tiny text, but it's just there as more something you can come back to. But in the report that we published, we've just shared some examples of signs and symptoms, which are kind of similar to some of the ones that you've just mentioned, actually. And I think one of the ones that just struck me was under operational frustrations. There was a story in the BMJ, because I think it's something we can all identify with, trying to book an appointment. And this was about a new mother had tried to book the routine vaccination appointment for the baby, and it took 4 attempts plus a complaint to the practice manager, and all the time they're getting these reminders saying, don't forget to book your appointment, and they're just not able to because the slots are already gone, or the book isn't open yet, the booking's not open yet for that particular date. And I think that just felt really resonated, because I thought, oh gosh, that's something we've all experienced. And that feels, relatively speaking, that feels like something that could be addressed. And then, you look at some of the others that are probably a little bit harder to address, but and probably need that sort of collaborative approach. But I just thought it'd be helpful to share some of the examples, and there are more examples in the report as well, which might be helpful to just getting a sense and getting your head around it as well. So I just wanted to talk a little bit about why this matters. And I mentioned at the start that it ended up being a bit of a story about people rather than just about productivity. And I thought I'd just share some of this, although it's actually, some of this is coming through from what you've shared as well. So it's not just the fact that, we're potentially wasting valuable resource. There is a really hidden burden on patients and carers. So, that might be time, emotional energy, sometimes money with traveling and stuff, trying to navigate these services. And that's not really visible in our sort of data, this sort of impact that we're presenting to patients. And in the workshop, the stakeholder workshop, we talked a lot about end of life care, because I think there was a recent Health Select committee on this about that reported about people feeling they had to go into battle with the system, and carers having to give up work to navigate these different services and pathways. And as well as that, we've got the workforce impact. So we heard a lot from people about this sense of purpose being eroded by constantly dealing with failure demand, and that causes burnout, attrition. People reported the reports about this. I can't remember the name of the book, but it's mentioned in the report, of clinicians feeling that they're just doing quite mechanistic roles and not really doing. It doesn't really match to the value of their profession and what they went into healthcare for, really. And so you get disengaged, disillusioned staff, and that limits capacity. It generates further failure demand. It generates more of a risk for patient safety as well. But there's also a really strong equity theme coming through, because this sort of equality-based models will be good for most people, but there'll be a proportion of patients that this sort of rigid eligibility or thresholds just don't work, or these sort of very standard pathways just aren't adaptable or flexible enough to work for people with more complex needs. And then, of course, there we've got the fact that failure demand sort of seems to generate this sort of demand amplification, and so unresolved needs are then appearing, sometimes more complex or even more costly forms of people that, for example, rocking up to A&E because they can't get their needs met elsewhere. So I think it's worth just reflecting on some of that, and I think I guess there's a lot of, I suppose, incentive to trying to address this problem, identifying and addressing failure demand. So I'll just put a couple of questions here, not necessarily to answer now, but more things to mull over, in terms of where might we be seeing only part of the picture, and where might we be missing where demand is being shifted elsewhere. And that's, I think, part of the problem with failure demand is that where it appears isn't necessarily where the problem originated. And because of the way the system's set up, sometimes there aren't incentives for organizations to address failure demand where it's sort of appearing elsewhere. So there's a bit of an issue there, I think. So yeah, I guess in your day-to-day work, where might you be seeing only part of the story? Are there situations where activity appears high or it appears to be rising, but you can't tell if that's reflecting genuine need, or is it reflecting unmet need or burden being shifted elsewhere? So is one part of the system appearing to be coping, whereas another part, that demand is maybe being displaced? So these are the sorts of questions I suppose this sort of concept really provokes, and I think that's why it's quite interesting. So again, not expecting you to answer that now, because it's something you might want to think over, but just something to mull over at some point. So I guess if you were interested in starting, I suppose there's a few sort of, not lessons, but a few sort of findings, I suppose, that came through from what we've done in terms of, where might we start to address or identify and address failure demand. And I think what came through really strongly was this sense of it's very challenging, because it's challenging to define. It's, you can't really quantify it very easily, and actually measuring it as trying to get a metric for how much failure demand there is would be counterproductive, because it wouldn't really help us address the problem necessarily. And it could incentivize lots of gaming, for example. But what we do is instead look for sort of signals, look for some of those signs and symptoms. So where there are patterns of repeated referrals. So one example that we've got in the report is from NHS Resolution, where they were looking at, repeated failures to diagnose cancer, for example. So people had so many different contacts. And so, there may be something about thinking, well, actually, if that's happening, if we're seeing repeated referrals in the data, maybe there's something that we need to think about there. And that, it's their sort of extra utilization associated with the long waits and things like that. So I guess it's thinking about what those signs and symptoms might be, and thinking. I think what we found was that, moved forward too quickly. Was that, I guess, the data can only tell us part of the story. So there's something about observing some of this failure demand, and some of the people we spoke to who've done a lot of work in this space were saying that actually there is value in people seeing this for themselves. So they spend, for example, quite a few people have done work in general practice where they observe the phone calls coming in and things like that. And for some senior managers, observing some of this actually then leads to a bit of a change in mindset. And so there's something about sort of seeing and believing it, I suppose, really. But also there's something about our patient feedback, staff feedback as well. And so some of the sort of stories and more narrative type evidence. So these all help to, I think, build a clearer picture. And in the webinar last week, Stephen Rocks from the NHS Productivity Commission that the Health Foundation is running, he did a really nice slide about some of these different sort of sources of knowledge or information and data about failure demand, which helped give a sort of more complete picture, I suppose. And then lastly, I think there's this sort of being able to work across boundaries. So, particularly for the top part of the typology, the demand really sits in one sort of data set or one place, and failure demand is often not contained in one of those quadrants. It sort of spreads, I suppose. So I think those are the sort of the three key, I suppose, messages to think about in terms of where you might start to explore failure demand. And so I think, the question we asked ourselves when we were doing this work was, could this concept help improve the NHS? And I think our answer was yes, but with some caveats. So like I said, the concept, people get the concept, but it is quite hard to pin down. And in a sense, that ambiguity isn't really too much of a problem, because we're not going to try and measure it and quantify it. But it sort of maybe helps instigate some conversations within teams, organizations, or systems to sort of think about this and whether there are things that we could be addressing. you know, some of which maybe it's maybe starting with some of the operational frustrations, which is relatively more straightforward, might be a good starting point. But I think there's something in the concept, and you know, I think you could, if you were skeptical, you could say, actually, does this offer us anything more than some of the existing ways of looking at things, like technical and allocative efficiency? And you know, to an extent, that could be right. But I think the value of the concept of failure demand is that it sort of maybe is a bit more, resonates with more people. And I think there's something about bringing in that sort of patient carer and workforce perspective. And it's something that maybe people can get on board with more than sort of quite technical jargon, maybe. And I think it helps to bring into sort of sharper view this sense of asymmetry that you know, sometimes the patients are bearing the burden of failure demand more than the NHS. And I think Jacob Lant was challenging us in this webinar last week to sort of say that we need to perhaps recognise where we're normalising failure demand and really start thinking about how we can address it as a sort of priority, I guess, really. So because it sort of resists this sort of neat definition, I think that it's, I guess, identifying it does remain a little bit difficult. And I think that it does then rely on judgments of value, I suppose. And I think there is something about recognising that, you know, when we look back retrospectively, some of those decisions, when you look in hindsight, some of those decisions you can point out where, you know, where there've been failures, but at the time it's not always easy, I guess, to see the sort of fuller picture, I guess, really. So there are some limitations with that sort of retrospective view, I think. We also had a sort of bit of a debate about the term itself, failure demand, because the term, you know, failure is quite an emotive word and it has lots of negative connotations. And I think that some people are arguing, oh, perhaps we should describe it in a different way so that it sort of doesn't sort of create antibodies, as it were. But others were saying, actually, no, let's name it for what it is, and actually that might help. I suppose get some traction with senior people and boards, and for example, because it's sort of quite a strong, bold term. And then I guess that I mentioned about this sort of there's some sort of structural barriers as well. So this idea of that failure demand might generate away from where it sort of started, in a sense, and it might not be in different organisations or teams interested to address it, because there's something about the cost is not always born where it's where the problem started from. So I think there's limitations, I think, around the concept, but ultimately I think we concluded that it could be a useful lens for looking at things, because it does sort of, I guess, invite a sort of change in mindset about thinking about the impact of failure demand. But I wanted now to pose the same question to you. And I just really value hearing your thoughts on this. So does this feel like a useful concept to you? And if so, why or why not? You know, what is your reactions to this? And I think at the start, I think there were quite a few people who weren't so familiar with this term, and some people have sort of heard of it, but less confident maybe explaining it to others. So I think we've got quite a mix of experience or familiarity with the term. So I would be really interested to hear what you think. And I think we have got a Slido question set up for this, haven't we, Rachel?
We have indeed, and people are already sort of typing away on that as well. So that's great. That's great. So I think as you explained it, so I think just under half hadn't heard of it, but sort of over 2/3 didn't know enough about it. So I think you've explained what we mean by it, and I think people maybe tuned in quite quickly to what it is. I suppose now the trick is to relate it to people's own sort of areas of work, and just decide whether it's useful or whether it's, well, I mean, some people might think, well, you know, we kind of know all this these scenarios and some examples that people have shared before. We're kind of we're aware that the cause and effect of something not being done right has, you know, consequences. But I think what's useful here and what you've gone through is just the lens that you're looking at that situation through. And it's one thing saying, this isn't right, and we know that 111 does this, and we know that that doesn't do that. But being able to just frame it slightly differently to help the people to help the people who are maybe causing that failure demand understand the impact might be the thing. So that's where sort of analysts and others, if they can start to think, well, actually, if I can just demonstrate within our system, within our organisation or team, or even a specialty, what the impact is of certain things not happening or happening in the wrong way, then it might have a really positive effect. So I'll let you have a look at what people are saying, Alison.
Yeah, that's brilliant. Thank you. Yeah, and I think a lot of people are sort of suggesting, yes, it does feel like a useful concept, and I'm just looking at some of this and thinking about so I think there's a comment about more familiar with the term unmet needs, because that's part of the JSNAs, for example. Getting an outside-in perspective, what matters to people, thinking it'd be useful to discuss when looking at productivity measures. So yeah, that's great. Thank you very much for sharing that, everybody. And I think it is interesting because I think there is obviously a large conversation about productivity at the moment, but I think there's also an awful lot more coming out about relational services and this sort of sense of have we become kind of too industrial in healthcare, and are we missing some of the sort of more human social side of things. So it is really interesting, because I think it does sort of for me, it sort of triggers a lot of conversations and a reflection about, are there things we could be doing completely differently? And given the pressures that we're under at the moment, is now a really good time to sort of reflect on some of this and think, we can't sustain the NHS as it's going. And so we do have to think about some quite bold changes, I think. So I'm just conscious of the time, so I'll just quickly skip through a couple more slides, and then I think that should be me done. So shall I? I will just share my screen. There isn't an awful lot more to go through. Let me just find where I am on here. There we go. Yeah, so I guess so. If I was going to leave you with 3 points, I think these would be. It's always 3, isn't it? I think these would be the points that struck me. I think it's really this sort of really good lens for inquiry, I suppose, and that's, for me, it's about starting conversations with people and sort of socializing this term, I suppose, to think through what are the implications for how we design services. And I think one thing I haven't mentioned, but it is in the report, is obviously we've got failure demand in the system that we need to identify and address, but there's also a risk that we introduce more failure demand by poor design. So there's something about being aware of this for sort of prospective work as well, and thinking about how we design effectively. And there's all sorts of things about really proper co-design with patients and carers and communities that we need to probably think about. Also that the point about rising activity doesn't necessarily mean rising value and rising productivity, and I think that's something that has come through in quite a few of the comments. And then this sort of, sense of like, where is this showing up? What might we learn from this, and what might we be able to do with this? And I guess, there's a role all of us can play. We've all come with slightly different disciplinary perspectives, but there's something about how we might bring those perspectives together to collectively, make sense and act on this as well. So I just end by encouraging you to reflect, having thought about this for a little bit of time this morning, looked at the typology, what might the implications be in your context? What would you like to know more about? What, if anything, might you do differently? And I think, again, Rachel set up a slide here. If you're happy to share that, I'd be really interested to hear your thoughts and reflections. And I'll just close here with, these are the links to the various different resources. So we've got the report and my blog in the sort of lower left corner, but we also had a couple of guest blogs. So Jacob Lant, Chief Exec of National Voices, did a blog for us, and Anna Parry, who is the Chief Executive of the Association of Ambulance Chief Executives, giving a sense of, what is the impact on ambulance services, which is really fascinating as well. And the recording from last week's webinar is also available on our YouTube channel. So there's lots of QR codes there. I appreciate. We'll probably just need to put them all onto one page, so we can just give you one. But hopefully, you can click on those and they will direct you to those different resources. And do get in touch after today if you've got any questions or thoughts or reflections. I'm really interested to hear, and I can share my email address in the chat if that's of interest. But thank you very much for listening to me talk about failure demand for so long. Thanks for participating and sharing your reflections and thoughts. I'll hand back to you, Rachel.
Thanks, Alison. That was your timing is impeccable, of course, and that's good. We haven't covered. We've covered probably around about 20% of what people have shared. So I think there's been some really, really useful sort of questions and observations about terminology and looking at who's impacted and how they're impacting everything. So I think there's lots of things that I'll share with you after. So I think it will help with next steps, with this work, which didn't come to, I don't think. Somebody did have their hand up, but it's gone, so I won't come to them. Somebody has put a point in the chat. Oh, we have somebody who's.
Hi, Rachel. Sorry, it's me, Siva here.
Oh, hi,
Apologies.
Siva. Have you got a comment or a question?
A very quick question.
Sure,
this is all
go
good,
ahead.
but I think the things that we have covered so far is almost everything that we know about. Sorry, put my face down. But I think the key issue here, one thing I have noticed is actually, I think the demand in staff and the demand in budget is something that we can't do anything about, the NHS. But what we can do something about is about minimizing the processes that are taking to. For example, to get that test done for my mom, I have to have like 3 or 4 interactions to be done with the GP to get it done. Right? It takes about 3 or 4 weeks for me to get it done. And why is that? It can be done within one contact or a call. How can you make it easier? I think that's the first thing. And second thing is training front level staff well. Most of the responsibility lies on the shoulder of the reception staff or people like nurses and HCAs rather than the actual doctors and the consultants. And that is a major problem here. They couldn't handle it, the pressure. That's why having so many strikes, people with low paid jobs having much pressure than the higher paid ones taking.
And lots of impact, lots of influence because of the roles that they have and everything. No, that's a good point. Yeah, thanks very much, Siva. Okay, thank you so much for that. We had, like I said, we had lots of questions before, and there are some other millions of unanswered questions as well. And so, God, you're going to be so busy after today. I know, you give us your time, you share all this work with us, and you make it sound extremely interesting because it is, and relevant. Everyone can see the relevance, else I wouldn't be here as well. But also, I think I just think there's some really rich stuff in what's been shared. So I won't force you to answer that in like 60 seconds, which is what we've got left. So I'll just say thank you again for that, and I'll share those with you afterwards. But what I will do is I'll just have a quick look at what is upcoming in the next couple of slides, because I'm sure there's something. Drum roll. The next slide is not that. I think I had a bit of a delay, and that is not in fact relevant, and nor is that. And I'm now in a mild panic as I haven't got anything to share with you about upcoming huddles, but I'm sure I have. So just bear with me. Here we go. Let's just do this one here. This looks like I'm just going to keep. There we go. It was the one after that. Oh, silly me. What a silly Billy. So we've got AFA joining us next time. So they're going to be talking about, we haven't had AFA for a bit. So they're going very strong, and they're getting involved with lots and lots of things. They're going to be talking to us about their specialist networks that they've got that they are effectively form the umbrella for, and that includes women in data and a population health management network as well. So I'm looking forward to finding out more about them and hopefully some inclusion of maybe one or two others or leads of those networks as well. We've then got excited about this one as well. So this is somebody who is from Pittsburgh, and so the timing of this will mean that it's quite early for her. So do show up and give her some support. So this is into July. This is decision quality and the use of AI and clicking. So it's quite precise and focused, but the relevance and interest, I think, will be quite a lot broader than just clinical decision making. Then we have the Midlands Prevention Pathway Toolkit, and this is into September, and then just as a sample of what we've got in October, looking forward to this one. So this is Better Homes, Better Health, Insights from Linking Housing and Health Data. That's with Tom Prendergast from the Health Foundation. He's a regular presenter here, and he's been at Hacker as well. So he knows the score, he knows what you want to see, and he's back to share more of that. If you'd like to share your work, please do. We'd love to hear from you. I leave gaps in our program to be flexible with that. So I'm going to stop sharing now. And oh, would you just look at that time? Thank you, Alison, again, ever so much. Really enjoyed that. Thank you for everybody for coming and sharing your thoughts on failure demand. And I hope you've got something from the session today. I'll see you in a couple of weeks. Bye-bye.